Let us talk about the diffuse disease of the liver. Firstly, the benign diffuse disease. Among the benign diffuse disease are hepatic steatosis, cirrhosis, viral hepatitis, hemochromatosis, and iron overload Wilson disease. Hepatic steatosis, we will talk about hepatic steatosis now. Here, triglyceride overload occurs in hepatocyte. The cause are acute and chronic alcohol abuse, obesity, diabetes mellitus, insulin resistance, cystic fibrosis, malnourishment, total parenteral nutrition, tetracycline, steroid, and ileal bypass. Hepatic steatosis on ultrasound shows increased parenchymal reflectivity and therefore obscures the portal vein margin. But increased reflectivity can also be seen in fibrosis. So we can do CT scan. CT scan even quantify. CT scan shows rise of 1 to 6 Hounsfield unit per milligram triglyceride per gram of liver. But the confounding changes such as fibrosis, drug treatment, and conditions such as hemochromatosis make this quantification unreliable. MRI is most sensitive and specific for hepatic steatosis. Dixon-based chemical shift or in and out phase imaging allow both accurate diagnosis and with appropriate T2 and other corrections, accurate quantification. MRI is also most accurate test for diagnosis of focal fat variations. Let us talk about cirrhosis. Cirrhosis occurs as an end result of many diseases. The early changes of cirrhosis can be seen on histology. Then when widespread fibrosis and nodular regeneration develop, then we see on imaging. So on cirrhosis, two things happen. One is fibrosis and one is regeneration. Anatomically, advanced cirrhosis shows commonly in case of advanced cirrhosis, we commonly see atrophy of the posterior segment of the right lobe. That is the segment 6 and segment 7 are commonly atrophied. And we frequently see hypertrophy of the caudate lobe and of the lateral segments, that is the segment 2 and 3 of left lobe. In primary sclerosing cholangitis, in virtually all cases, caudate lobe hypertrophy is seen. Also, occasionally we see lateral segment of the left lobe, that is segment 2 and 3 is atrophied. Ultrasound of cirrhosis shows nodularity of the liver margin, and this nodularity of liver margin is found in advanced cirrhosis when ascites is present and when using high frequency transducer. Ultrasound also shows increased reflectivity, coarse or heterogeneous texture. Progressively the texture is become heterogeneous or coarse, but this is subjective. On Doppler ultrasound of cirrhotic patient, if we examine the hepatic vein, we will see damping of the normal right heart waveforms. And if we examine the main portal vein, then we see decreased flow. The mean peak will be less than 10 cm per second, or we may see hepatofugal flow of main portal vein. Occasionally, increased flow in a large recanalized parambilical vein is still blood from right portal vein. So the flow is reversed in the right portal vein, but the flow is normal in left portal vein and main portal vein. If we Doppler on hepatic artery, we will see that hepatic artery is enlarged. The rule of elastography uh, on cirrhotic patient is still not clear. CT scan also shows nodular margin, lobar atrophy or hypertrophy, parenchymal heterogeneity as like ultrasound. MRI delineates the morphological changes of advanced cirrhosis. When other technique is unhelpful, MRI provide non-invasive assessment of portal vein patency along with flow direction and backflow volume estimation. Angiography for cirrhotic patient may be used to assess vascular complications such as variceal bleeding and portal hypertensive change. So let us talk about viral hepatitis. On ultrasound, if viral hepatitis is echoed, then we will see decreased reflectivity, but in majority cases it is normal. Commonly we see gallbladder wall thickening, and in case of chronic hepatitis, if the cirrhotic criteria are advanced, then we will see on imaging as we described earlier. Let us talk about hemochromatosis and iron overload. Inherited genetic In case of inherited genetic hemochromatosis, the risk of malignancy is increased. Here, iron is initially accumulated diffusely, but as cirrhosis and regeneration starts, uneven distribution of iron is happened. In inherited genetic hemochromatosis, iron also accumulates in other organs including myocardium, skin and endocrine gland. Let us talk about iron overload. Iron overload occurs from multiple transfusion such as that is known as hemosiderosis. Here, iron accumulates in reticuloendothelial system in liver, bone marrow and spleen. MRI is very specific for diagnosis focal iron overload, not focal. That is iron overload. Also, T2 star weighted gradient echo is most sensitive. When iron accumulation is significant, then we will see low signal intensity on T2 weighted images, and if iron accumulation is severe, then we will see low signal on T1 weighted images. Iron overload in other affected organ. In case of iron overload in other affected organ, we will see low signal intensity on T1 weighted imaging. On CT scan, iron overload liver shows high such as more than 75 Hounsfield unit, but the changes are unreliable because of the confounding effect of steatosis. On ultrasound, iron overload shows increased reflectivity. Wilson disease. In case of Wilson disease, we know copper is accumulated not only on liver, then other sites such as sclera, retina, sclera. It is also accumulated, and it is toxic, and it starts the cirrhotic process. Imaging is not specifically useful for diagnosis. Let us talk about malignant diffuse disease. Malignant disease occasionally diffusely infiltrate liver. Usually metastatic disease, for example breast carcinoma, can infiltrate. Here we see diffusely liver shows increased echo-reflectivity and heterogeneity. Um, Malignant infiltration also occurs in some primary hepatic tumors, including hepatocellular carcinoma, and also in lymphoma and leukemia. In lymphoma and leukemia, ultrasound shows non-specific decreased reflectivity. Although other abnormalities, for example, presence of vascular thrombosis with hepatocellular carcinoma, may helpful with appropriate clinical context, biopsy may be required for such diffuse malignant disease presentation on imaging. So this is all for today. Thank you for listening.